So, good day, dear delegates, dear friends. It's an honor and a pleasure, also on behalf of my colleague moderator, Professor Dilip Lobo, to welcome you on this first series of Saturday webinars organized by the ERAS Society. So first of all, I would like to thank our sponsor 3M for their unrestricted grant, which made this webinar possible. I also would like to thank Goose and their interpreters for their excellent technical support today. So furthermore, I would like to thank Professor Miao, President of the Shanghai Anesthesia Society, for their support and collaboration with them in China. So today's webinar on ERAS and COVID-19 will also be broadcasted again later today in the Americas, North America and Latin America. The final broadcast will be 1 week later, both in China and Australasia. And we also run the entire show live in 5 languages: English, Spanish, German, Mandarin, and Japanese. And this webinar will, after March 6th, be available on the ERAS Society website. Well, so today's webinar on ERAS and COVID, and we have invited top speakers who will address ERAS and its perspectives of COVID-19 from several parts of the world. After the talks are delivered, there will be a Q&A session with members of the ERAS Executive Committee. So you are all invited to ask your questions through the chat box. So when we go to the next slide, the Lancet, we go back 1 year earlier. So early 2020, the Lancet published a paper on the mortality and pulmonary complications in patients undergoing surgery with perioperative SARS-CoV-2 infection. And it was an inventive of the COVID Search Collaborative. And they stated that the impact of severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, on post-operative recovery need to be understood to inform clinical decision-making during and after the COVID-19 pandemic. And this analysis included more than 1,100 patients who had surgery early last year. And on the next slide, they concluded that post-operative pulmonary complications occur in half of the patients with perioperative SARS-CoV-2 infection and are associated with high mortality. And the conclusion of this paper was that threshold for surgery during COVID-19 pandemic should be higher than during normal practice, particularly in men aged 70 years and older. And moreover, consideration should be given for postponing non-urgent procedures and promoting non-operative treatment to delay or avoid the need for surgery. So that brings us to the next slide and to our today's program, because the impact of COVID-19 continues to affect us all. We have to focus on how we provide the best in perioperative care during and after the pandemic. So when major elective surgery restarts, ERAS principles will be more important than ever to ensure high quality, value-based care with low complication rates. So the next slide, you can see our program, and I would like to invite Professor Olle Lundqvist. He is Professor of Surgery at Örebro University and the Karolinska Institute in Stockholm, Sweden. And of course, he is our well-known Chairman of the ERAS Society. So I would like to invite Professor Olle Lundqvist to give his talk. Thank you.
Hello, everyone. I'm Olle Lundqvist, and I'm the chairman of the ERAS Society. And it's a true pleasure to have you join us today for this special web seminar about the role of ERAS during the pandemic. And that is the title of my presentation today as well. So these are my disclosures. If we just take a quick look back in time and review the figure up on the left-hand corner showing the development of COVID COVID-19 over the last year or so. And you can see in yellow the numbers in the Americas, and in green the ones in Europe, and the other colors represent other parts of the world. But the slide shows clearly it's these regions that have been hit the hardest, and they still are. If we look at the graph to the right, World Health Organization recent update on the activity of the virus in different parts of the world. There have been taken a lot of different measures to control the pandemic. We all aware of the lockdowns, restrictions in movements and travel, the use of masks, and the hygiene recommendations, etc. And more recently, thanks to the fantastic work of the pharma companies, we have vaccines that are beginning to spread. And they seem to be work. Israel is by far the country who has vaccinated the most. And in the population above 60 years old, 90% are vaccinated. And they're seeing a drop in cases of 42%, in hospitalization, 30%. In the group below that age, the vaccination is less frequent and the drop in cases is not that clear. But this is an indication that the vaccination seemed to work. But overall, you can see from this world map that it's only a few countries that have been really getting underway with this. And overall, less than 0.5% of the world population has been vaccinated. And in the meantime, we're seeing that we have mutants taking over, like this one in the UK, where they found a new mutant sometime last year. And now the yellow bars here show that it's completely taken over from the one that initiated the pandemic there. And this is also spreading to other parts of the world. So it's already present in parts of the United States, as shown on the graph on the right side, as are other mutants of this virus. So it's going to be a race against time. Get enough people vaccinated, control it, while dropping the making less of threat of the mutations. So what about COVID and surgery and all of this? Well, it had immediate effect on surgery because we were flooded with patients who needed immediate care. So we reorganized hospitals, shut down operating rooms to develop ICU beds, deployed surgical beds for COVID, and relocated and retrained surgical staff to deal with these patients. And of course, this had an enormous impact on how much surgeries were done, and we're seeing a fast growing queue of patients, and we still are. It was evident very early on, already after looking at the first 12 weeks of the pandemic. This group, the COVID Surge Collaborative, published a paper estimating that 28 million patients had been delayed from surgery and canceled, and 2.3 million of those were cancer cases. If we look at the situation today, two recent papers, editorials from the UK, indicate that the UK backlog is 2.3 million for the country. That is about 34,000 per million inhabitants, and 4,000 cancer operations have been delayed. So still a lot of work to do. Now, I use these numbers to get a feel for an estimate, a very rough one, on the problem we're facing worldwide. And I picked the three regions that were mostly hit by the pandemic: EU, USA, and LATAM. And you can see only with these three countries, regions, we're talking almost 40 million cases. And that's telling us a little bit about the scale of what we're facing in the future. So we're facing a massive backlog of operations, limited resources, economic strain. So the demand on us is going to be to deliver faster, better, and cheaper care. Many have discussed how to manage surgery during COVID-19, and the focus has been to maximize available resources, which is absolutely the right way to go, avoiding cancellations, add extra hours, speed up changeovers in operating rooms, and prioritize the right patients, obviously. And these have calculations on the effect of what that can do. Well, the ERAS Society is offering something different: deliver even better care. ERAS. Because we know ERAS results in faster recovery to free up beds, avoid complications, will liberate the ICU situation, and all of that will save cost. I'll show you some data to prove my case. Because the ERAS Society can help with COVID-19, and ERAS will do the trick for us. We have numerous guidelines in different surgeries telling us what the literature suggests we should be doing, and we know that they work. Because when you employ ERAS, we showed more than 10 years ago from randomized trials in this meta-analysis that complications come down up to half. This is colorectal, and similar figures have been shown for other surgeries. And we also know that it's because of the guidelines, because the better you comply with these guidelines, the better your outcomes are going to be, fewer complications. And this has been repeated over and over again in the last 10 years. We also know that because of this, there's going to be large-scale implementation savings. Well, savings for everyone, actually. This is from Alberta Health Service, multiple ERAS protocols implemented throughout the state, and the return on investment as high as 7. Huge savings to be made. We also know that the ERAS guidelines can be implemented in a structured way. This is the first report from the Netherlands showing that this training program takes about 10 months. It reduces length of stay by 30 to 50% as people are employing to use ERAS. So we have now refined and developed this implementation program even further, and we're offering an 8 to 10 month team training to help ERAS teams to run data-driven change management. And the effect is going to be seen already during the program after 4 to 6 months or so. And this is also available online to be able to do it during COVID or at the end of COVID. And this is something that we've been doing across the globe with more than 250 units in 25 countries, many of them trained to be trainers. So we can help a lot of people through this organization. If you want to know everything about ERAS, you can find it in our textbook that just came out last year. You will find it through our website. So to sum it up, we're facing a massive backlog of surgical operations. We only have the limited resources we have to deal with that, and we're very likely to face economic strain. So again, faster, better, cheaper care. We would say that we can do a lot of that with employing ERAS, faster recovery, fewer complications, saving cost. And we know we can change. So this is changing to best practice, and COVID has shown us that we were capable of making very drastic changes. So let's use that, because my conclusion is that ERAS is needed more than ever during, but also after the pandemic, and really as a way of moving surgery forward also in the future. I thank you for being with us today. Enjoy the rest of the talks, and good luck out there.
Thank you, Oli, for that excellent overview and for setting the tone for today's webinar. I now invite Professor Tim Rockall, who's Professor of Surgery at the University of Surrey and also Consultant Surgeon at the Royal Surrey County Hospital in Guildford. Professor Rockall has got special expertise in laparoscopic colorectal surgery, and he probably runs one of the best ERAS units in the UK. So he's going to talk to us today on minimally invasive colorectal surgery and COVID-19. Over to you, Tim.
Thank you for asking me to talk about colorectal surgery and COVID. There are two prominent issues to be discussed in relation to colorectal cancer surgery and the COVID pandemic. Firstly, and obviously, the infection risk to both patients and staff. Secondly, delays in treatment due to access, staffing and resources, which include the potential for disease progression due to both delayed referral and delayed investigation. Also, the risk of transferring from an elective pathway to an emergency presentation, and the transfer to an oncological treatment pathway which may not represent best care. On the plus side, patients may be effectively released from arbitrary treatment targets to allow more time for patient optimization. During the lockdown periods of the pandemic, we have mostly been restricted to operating on the two highest priority groups, which for all intents and purposes means emergencies and cancers. Colorectal cancer has been prioritised along with all other cancers, but there have still been significant delays to treatment in many hospitals. Having said that, for many colorectal cancers, especially early stage disease, delays of a few weeks or even months probably has little impact. Other issues that have cropped up are that most colorectal cancers are now treated laparoscopically, and the potential for increased risk with that technique, and the knowledge that complication rates are very high should the patient be infected or become infected during their admission. As the first wave rapidly took hold, there was a rush to produce guidance on how to deal with these issues, and the early advice was to avoid laparoscopy to protect staff, and to avoid an anastomosis, not just because of the higher risk of complications, but also because there would be a reduced ability to rescue those patients who had developed an anastomotic complication as a result of reduced access to intensive care facilities. In the USA, the American College of Surgeons graded their advice according to the phase of the pandemic, as illustrated here. You can see that only in phase 3 was all but emergency surgery deferred, so most hospitals have continued to treat colorectal cancer patients, albeit with some delays. So what are the risks to surgical staff? The main risk comes through close contact and inhalation of aerosolized particles. The anaesthetists are particularly at risk during intubation and extubation, but the surgeons are also at risk because of the potential presence of viral particles in gas escaping from a pneumoperitoneum, as well as in the steam and smoke generated by energy used in open surgery, such as diathermy. Here are some images showing the hidden problems of gas leaks during routine laparoscopy that makes this a potential risk. And advice has been generated in order to mitigate that risk. The consequences of the early advice, however, clearly significantly disadvantaged the patients. The advice was understandable because of the urgent demand for advice in the context of health systems, such as those in Italy, being rapidly overwhelmed. But there actually was very little evidence to draw on, and for many practitioners, based on an assessment of balance of risk, the advice regarding laparoscopy and stomas was often ignored. This was recognised in the SAGE's EAES advice, which confirmed the lack of evidence behind the increased risks of minimally invasive surgery, and indeed stressed the advantages. It did, however, recommend practices that would help to reduce the risk, including enhanced PPE, ventilation systems, gas filtration, and things like that. The most useful advice, however, is of course around testing to ensure as much as possible that the patients are COVID negative at the time of surgery. The biggest problem in COVID patients undergoing surgery is the very high incidence of post-operative pulmonary complications, which is both very common and carries a high mortality. This is only a problem, however, for patients who are incubating the virus or indeed contract the virus whilst in hospital. A problem mainly for the emergencies who cannot delay their surgery. So with regard to laparoscopy, we and many other hospitals continue to deliver this as safely as possible for all the established benefits. Indeed, laparoscopy reduces pulmonary complications more than any other single intervention. Laparoscopy and ERAS could be argued are more crucial than ever in reducing dangerous complications and reducing hospital stay and reducing ITU usage. So, are any of the modifications to a standard ERAS protocol necessary? In the preoperative state, on the one hand, any surgical delay represents an opportunity for better optimization. But on the other hand, this is made difficult by reduced face-to-face contact, which has been ameliorated somewhat by the greater use of teleconferencing. And another example is the reduced ability to admit patients to infuse iron in the anemic patient group. And this has led in some cases to a greater reliance on oral iron supplementation given over longer periods, which is to some extent enabled by the delay in operation. Improving aerobic fit has been a challenge, but perhaps less relevant to colorectal surgery than in other GI specialties. There has been reduced access to cardiopulmonary exercise testing. Adaptation of the test in post-COVID patients can be difficult. Also, delivering prehabilitation programs remotely is less well established and its effectiveness less certain, as is the effectiveness of alcohol and smoking interventions. There is, however, potential for delivering these items remotely, and research into how best to deliver this both to prevent deterioration and enhance aerobic fitness is needed. Intraoperatively, some units in the early phase of the pandemic were challenged by drug and indeed oxygen shortages, but certainly in the UK, this has not been a persistent problem. In the push to reduce postoperative pulmonary complications, the confirmation of adequate neuromuscular block reversal has perhaps increased in importance, and the use of Sigamadex is important to achieve this. The ERAS basics of avoiding hypothermia, hyperglycemia, optimizing fluid therapy, and offering multimodal analgesia really remain unchanged. It is worth stressing that minimally invasive surgery is one of the few independently significant variables in the ERAS protocol that improves outcome, and there is no doubt it remains the best way to treat colorectal patients. There is still really no evidence of increased risk to staff during laparoscopy, but that does not negate an emphasis on safe practices, which include skilled surgery of short duration, the use of closed gas circuits, ultra-low particle filtration, adequate PPE. The real key, however, is patient and staff testing to ensure that we are never electively operating on a COVID-positive patient. Post-operatively, the emphasis is on getting the patients out of hospital environment as quickly and as safely as possible. Here again, minimally invasive surgery and enhanced recovery are the best ways to achieve this. Reducing hospital stay reduces contact opportunities, improves recovery, and can be easily supported by telemedicine if necessary. It also unburdens the health service. So how best to serve our patients? Firstly, test and avoid operating if positive, observe PPE protocols, reduce hospital stay, and use those ERAS principles to reduce post-operative pulmonary and thromboembolications. This is supported by a recent paper from Turin that has compared outcomes for some similar periods before and during the pandemic in northern Italy. Absolute numbers of colorectal resections remained the same, and there were no differences in the number of patients treated laparoscopically and no instances of COVID in these patients. So in conclusion, optimal recovery for colorectal cancer patients is achieved by continuing safe laparoscopy with ERAS compliance more important than ever. The constraints and pressures of reduced capacity are an ideal environment in which ERAS can flourish. Thank you.
So, Professor Rockwell, thank you for your excellent presentation. And I would now like to invite to come for the presentation, Professor Mike Scott. Professor Scott is a Division Chief, Surgical and Neuroscience Critical Care Medicine at the Department of the Anesthesiology and Critical Care Medicine at the University of Pennsylvania in the USA. And Professor Scott is also chair of the ERAS Education Committee. So his talk will be how safe is surgery during COVID-19? So please, Mike, step forward and deliver your talk.
Hello, my name is Mike Scott. and I'm speaking to you in the University of Pennsylvania in Philadelphia, USA. I'm talking to you today about how safe is surgery during COVID-19. The outline of my talk will deal with the impact of COVID-19 on worldwide surgical volumes, risk of surgery for patients who've had COVID-19 or recent COVID-19 infection, and then the impact of surgery for patients who are actually COVID-19 negative, and also touch on the risk for providers. This slide shows data from a year ago, and it actually seems a very long time ago. It's the Johns Hopkins University global case map for COVID-19, and you can see back in, this is the 13th of March, only 137,000 cases worldwide and only just over 5,000 registered deaths. But as we move through to the next slide, by July, you can see we've gone up to 15.8 million cases, global deaths at 641,000. And then today on the 26th of February, 113,000 global cases. So in other words, 1,000-fold increase. But the good news is the deaths haven't gone up in the same ratio. So we are having improvement in outcomes and treatment of COVID as we've dealt with the disease. But the thing that this has had also is not just COVID, but the impact on surgical volume and capacity. This article in the COVID Surgical Collaborative Group, which is actually headed out of the University of Birmingham in the UK, shows the 12-week cancellation rates by type of surgery. You can see that benign surgical disease has actually almost come to a standstill for the first 3 months. Cancer surgery has been reduced a lot, and obstetric surgery mostly is still happening, but there is reduction around the globe depending on the resource allocation. The best estimate they came to was that the 12 weeks of disruption in the early part of the COVID pandemic, that 28 million operations would be cancelled. So that's about 2.3 million operations per week. And if you think that a lot of health systems haven't really got going and it's nearly a year on, it means there's anywhere over 50 million surgical cases that are still outstanding. And certainly, although a lot of these are benign cases, unfortunately, there's still about a third of cancer operations that have been delayed. And that is going to have a big downstream effect on patients' outcomes from their oncological perspective. And in fact, you can see that in this first estimate of just the 12-week disruption, there's a median of 45 weeks to clear that backlog. And we're looking at even more than that. So the effect of COVID really might have a backlog of anything up to a couple of years on surgical volumes around different health systems. So why did we have to reduce volume? Well, the obvious thing was risk of transmission of virus, both to the patient and providers, risk to the patients of developing infection while in hospital. And then we had evolving evidence, prevention, protection, and treatment in the hope that we would be able to get on top of the pandemic quickly and get back to normal, which hasn't really come as quickly as everyone expected. And along with that, lockdowns, and not just the first lockdown, but now second lockdowns, which has affected availability of staff and patients coming to hospital. And more importantly, availability of resources, particularly things like PPE, blood, and equipment, because the whole supply chains have been taken out by the pandemic. Italy was one of the first European countries to get really impacted, and this slide shows the impact on surgical practice in Italy, with the fact that there were lack of operating time, lack of blood. They had to develop COVID-19 surgical pathways to reduce risk, cross-contamination and exposure to staff. And then there wasn't always a place to put people afterwards. And I'll come and talk about surgery and actual COVID patients shortly. Because this paper from the Lancet early on was really quite alarming. It was looking at the mortality and pulmonary complications in patients undergoing surgery who had COVID, and it reported a 30-day mortality and pulmonary complication rate in 235 hospitals in 24 countries. There were over 1,000 patients that had surgery. About 3/4 had emergency surgery, 25% had elective surgery, and they showed that pulmonary complications occurred in over half of them, and the 30-day mortality in these patients was 38%, which is quite staggering. And then this was followed up by this, I think probably the best systematic review. They screened 715 articles with 45 articles included. And there were up to 3,000 patients in this group. It still revealed a high global rate of post-operative mortality in COVID-19 patients undergoing surgery, around 20%, a post-op ICU admission rate of 15%, and also increased length of stay. So surgical societies all around the world made their own recommendations. Here you have the American College of Surgeons, who developed elective case triage guidelines to effectively ration surgical care, but to give it priority according to need. And then, of course, the other key thing was to try and keep the emergency care system going. And that was vital at a time when people were stuck at home and often were getting ill without really good access to normal general practitioners or family practitioners. And there's been, in the last 6 months, questions in all journals and across all surgical specialties, how and when we ramp up a safe and effective surgical volume. And patients themselves have been asking the same thing. Should they have elective surgery in the pandemic? This piece up on the top right shows something that was in the New York Times. But what we have got and developed rapidly is the high sensitivity testing for COVID-19. And it's the improved access and number of tests that's really made the difference. And of course, now if we can time the tests and they're negative, the patients can get into hospital within 72 hours. They have a low chance of being positive. And so this has enabled many healthcare systems to basically get their volume ramped back up. Hospital infection rates to patients coming in appear to be extremely low, but reporting is inconsistent and guarded because no one wants a bad story. And the other thing is mortality and morbidity rates appear to be unchanged in non-infected patients undergoing elective or emergent surgery for case-matched examples in optimal healthcare systems. So those systems that are back to normal are functioning as normal with minimally increased risks, it appears. In the early weeks of COVID, there were significant risks for providers. Although these were mitigated by PPE, personal protection, of course, there was an extreme shortage early on. You're all familiar with these. On the left, you have a face shield with a N95 mask, which we use for aerosolization or when you've got an acute exposure to COVID patients in non-negative pressure rooms. You've got in the middle just normal face masks and with face shields, which protect you really from the majority of things we found now. Or if you can't wear an N95, you can have a PAPA or positive airways pressure helmet, like on the top right. One of my colleagues, Hao-Feng Wei, here at the University of Pennsylvania, published an article in the BJA, which was a consensus article, because it was identified early on that anesthesia providers were at higher risk of infection early on in the pandemic. And that group developed a level 1, level 2, level 3 protection strategy according to where you were giving anesthesia and the infectivity and aerosolization of the patient procedure. Of course, now we've got vaccination programs. It's the hope that basically PPE and vaccination will protect providers very effectively. So where are we with the role of ERAS in addressing the backlog of surgery after the COVID-19 pandemic? This review that Uli Lundqvist wrote with myself and our dear friends, the late Ken Fearon, really gave an overview of why ERAS works and why it's important in modern healthcare. There's a proven shorter hospital length of stay, less variance, less complications, and improved value. And it's even more important now resources are stretched and there's economic pressures on supply chains, availability of equipment, and availability of staff. So in summary, elective surgery has a huge backlog around the world. Patients who have COVID at the time of surgery have high complications and mortality. Providers following PPE recommendations and now with vaccination have a low, but we can't say negligible risk of infection. And ERAS is even more important in the era of COVID to reduce variants, complications, length of hospital stay, and improve the value of healthcare delivery so that we can start making inroads into this backlog that we see around the world in both emergent and urgent surgery, as well as elective benign surgery. Thank you for listening, and I look forward to taking questions.
Thank you, Mike. That was excellent as usual. We'll take the questions at the end of the webinar, and I'd like to invite Mr. Matt Perry now, who started his urological career in London and has now moved on to Guildford. He has a special interest in robotic urological surgery and cancer vaccines. And he's going to talk to us today on the delivery of ERAS during COVID. Over to you, Matt.
Hello, I'm Matthew Perry. I'm a consultant urological surgeon at the Royal Surrey in Guildford, and thank you very much for asking me to attend and present our experience of the first COVID experience last year. The Royal Surrey hosts the UK's biggest prostate cancer referral network. We have probably the second biggest surgical service for prostate cancer. We've got Europe's biggest brachytherapy centre, and we're probably the third biggest centre for cystectomy in the UK also. So COVID was bound to hit us. And as part of that, being prepared for that was part of the necessity that we had. So this is all about people, policies and places, and the flexibility of both the clinical and the management support that we had and still have actually in the second lockdown. We took advantage of our locality in the fact that we have a private hospital next door to the public hospital with a corridor adjoining the two, and how we use that extra facility really came as a beneficial thing for us. One of the first things, of course, was the fact that we couldn't see patients. We kept them away from the hospital for obvious reasons. And so everything was done by telemedicine. And of course, none of us were experienced in that. And in fact, none of our patients were either. Having said that, it was extremely well accepted by both doctors, nurses, and patient groups within the first moments of the pandemic, and continues to today. And so a lot of our learning from that first experience is the fact that we continue to do an awful lot, if not most of our services through virtual means these days. So the initial changes that were forced upon all of us, of course, were that our patients would have a PCR test and that they would need a pre-op CT scan the day before their operation. And this was abandoned fairly quickly after a couple of months with the new learning that came online fairly rapidly. The difference we had at Guildford, I think, compared to a lot of other places in the UK, was the fact that we thought that if the patients were going to have a PCR swab, then all of the staff would need that too. So from cooks to cleaners to consultants, everybody had a PCR test every week. And as has been found in other centres, somewhere between 5 and 7% of the staff were asymptomatic carriers on PCR. These had to be separated from our situation until they had a clear swab. We used the private hospital next door to the Royal Surrey. They're joined by a corridor underground, and using that, we were able to seal off the site so that doctors, nurses, theatre staff, cooks, cleaners, and the like were all kept in that environment, and we weren't allowed to travel to the COVID centres in the NHS hospital. And so we were kept away from COVID. And this was a small number of surgeons, a small number of theatre teams, and a small number of anaesthetists. And so we were able to work in small groups, fast, efficient, and clean and safe. And to do this, we needed an awful lot of management support. So the infrastructure had to be built, and this happened actually fairly quickly. So we downed tools with our robotic service, which is the vast majority of what we do, for a couple of weeks only, whilst all the IT infrastructure could be laid down before us. All of our clinics had to change. All of our theatre times had to change. There was no such thing as your regular job. We all had to change in the way that we were working, and our patients were all extremely satisfied with this and helped us through this. And this is just a short clip of us going through moving two of our 3 Da Vinci machines into the new setting. Cystectomy is our main big and dangerous operation, and we retained face-to-face consultations with regard to that, so we could develop that doctor-patient relationship. Having said that, the prehabilitation service that we have as part of our enhanced recovery was all done via telemedicine. All of the CNS, the nursing support, the stoma support, the pre-operation swabs and tests were all done in one visit, as opposed to pre-COVID, it was all done at various time points. We were initially told no laparoscopic surgery due to it being an aerosol generating procedure. This was put aside fairly quickly on so we could get on with robotics. But we did robotics in full PPE and at low intra-abdominal pressures. No teaching was allowed for the first couple of months, which was unfortunate but practical at that time. Post-operatively, our ERAS program did not change in the slightest. And so when we look at the first part of the pandemic and compare it to a similar few months in the previous year, our number of referrals declined quite dramatically with regard to prostate cancer. This has been recognised in various places throughout the country and Europe. Having said that, our radical prostatectomy numbers really went up dramatically, and our time from referral to diagnosis was massively improved, probably because we got rid of all of those people who were on our diagnostic processes that didn't need to be there. The number of brachytherapy implants dropped slightly, but this is a lower risk type of prostate cancer. Those men could probably wait for their treatment. With regard to bladder cancer, the bizarre situation has arisen in that our referrals actually went up, but our actual number of cystectomies went very much down. And this is because as a tertiary referral centre, we're reliant on our other hospitals referring in to us. And so we can't really control what they do. and so actually this probably looks at more of the rural Surrey itself's population as opposed to the population of the hospitals surrounding us. Having said that, our diagnostics for bladder cancer were much faster than they were pre-COVID. So we feel through this time we were able to get on and do our procedures as quickly as possible. And this was shown out with our NHS targets, showing that we, during COVID, were hitting the low 90% in our target rates. And this is from a target of 62 days from referral from the GP to the treatment time. This is an NHS measurement of excellence in some respects of getting patients through a process quickly. The previous slide shows the number of operations done from March to June, but in fact in June we did another 53 radical prostatectomies. So actually in that short time point of 4 months, we did more than 50% of our annual turnover. That's how dramatic we were and how flexible we were able to make that treatment service. So we feel that it was the flexibility of the staff to maximise the opportunities around us, but it was also the support of our management structure to facilitate that change in practice that led us to be able to do so much and actually so much more rapidly than we've done previously. Our patients were important too. They helped us with in understanding the situation, and we were able to send out reassuring messages via social media and the like to encourage them to come to hospital if required. And so through flexible working, increased surgical capacity and fast diagnostics, we were able to push through an awful lot of these patients, so much so that by the end of July, some of us were told to actually go on leave because we'd run out of operations. Our length of stay for these procedures was as short as it has been, so the enhanced recovery process throughout the pandemic did not take an impact at all. We were able to provide the length of stay of about 5 days for a radical cystectomy and 1 night in the hospital for radical prostatectomy, and that did not change throughout this whole service. Thank you very much for letting me go through our experience.
So, Mr. Perry, thank you for your excellent presentation. I would like to introduce now to two speakers. The first is Angie Balfour. She is lead ERAS nurse and senior research nurse in Edinburgh, Scotland. And she is also chair of the ERAS Society Nursing Group. The second speaker in this session is Valérie Ador, and she works at the Department of the Visceral Surgery at the University Hospital of Tuve in Lausanne, Switzerland. She is an ERAS nurse and coach and has trained over 60 teams in ERAS implementation all over the world. And these both speakers will talk about surgical nursing during the COVID-19 period. So please go ahead.
Hello, everyone. My name is Angie Balfour, and together with my good friend and colleague Valérie Ador, we are going to spend some time discussing the impact of COVID-19 and what impact it's had on surgical nursing and ERAS within our 2 units, one in Edinburgh, Scotland, and the other in Lausanne, Switzerland. Valérie, can you tell us a bit about some of the challenges that you have experienced over the last 12 months due to the pandemic?
Thank you, Angie, and good morning, everybody. From the first wave, the scheduling of surgical procedures was disrupted. And during the second wave, and especially from end of October, the CHU reduced its programmed activity in order to treat the influx of patients with COVID-19. And all non-urgent surgical and medical procedures, hospitalization, and also outpatient consultations that did not affect the health of patients were postponed. It should be noted that cancer patients were able to benefit from surgery within a reasonable frame time. And however, the reduction in operating theaters has led to a waiting time for other types of operations. The workforce thus freed up was able to be mobilized to cope with the second wave of the pandemic, and some interventions were carried out in partner hospitals of the CHUV, and those hospitals are half private, half public or private. And however, the ERAS recommendations were not implemented because the staff were not trained. So it's difficult for us to obtain the data for our database and to follow exactly the patients in the ERAS recommendations. The personnel freed were brought in to reinforce the teams in the service needing reinforcement, particularly the medical and intensive care services. This situation created a certain amount of stress in terms of organization, since employees were notified late of their day, schedule, and assigned department of work. And finally, it should be noted that the nursing staff was much more affected during the second wave. And the lack of staff and a larger number of patients than in the first wave caused additional fatigue for those who worked, and deployment to other departments was difficult for some. Finally, and between the waves, the medical nursing teams did not have much respect. For the patients, their care was adapted. Each patient had to undergo a COVID test 48 hours before hospitalization, creating, of course, additional stress for them while waiting for the results. And depending on the patient's clinical situation, follow-up consultations were partly carried out by telephone by doctor or nurses. And despite consultation, despite this, patients continued to benefit from the preoperative ERAS information consultation with the nurse. They were thus able to share their concerns with my colleagues about the COVID and all the situation. And during the first and second wave, family visits were suspended, and this probably added an additional level of anxiety for the patients and a workload for the nursing staff, providing psychological support to both patients and families, and especially in the intensive care units. And finally, in terms of research, a lot of work has to be suspended, and priority was given to research related to COVID-19, of course. And the same was true for the ERAS training given to service staff. That means that in my department, the new nurses, the new colleagues were not trained about ERAS. So it's quite difficult to have a good application of the ERAS recommendations. So what about you, Angie? What has the last year been like for you and the team in Edinburgh?
So not surprising, a lot of our experiences have been the same. Most of our elective surgeries were cancelled except for fit cancer patients. Non-urgent investigations were postponed. Some clinics were cancelled. Face-to-face consultations all but stopped. People also stopped attending A&E. They didn't go to their GP. There was a message really from the beginning to say to stay away from the NHS, to try and protect and preserve. So people were scared. And I think that that will have consequences later on about, delayed response time, etc. And also the waiting times will have a consequence to that. In terms of elective surgery with me, certain patients were designated as green patients, and they had to be operated on in another hospital, still within Edinburgh. But the more acute patients were still managed in the main hospital in Edinburgh. Obviously, the people more at risk with the higher comorbidities were managed where there was a critical care facility available. So we were able to treat the majority of cancer patients fairly urgently during the first wave. And the second wave, we've actually increased our workload to almost back to normal, certainly for the cancer colorectal patients. They are now all being managed back in the main hospital as well, so that's a lot easier for me to apply ERAS to them. Like yourself, patients need to shield now. They have to have 2 negative COVID swabs, but being under house arrest, if you like, it means that they can't go out and mobilize as much as they would like. So we perhaps can't optimize them in the same way that we would like. Being told to be as active as possible, but not able to go into the outside world. So that makes it challenging. During the first wave, the other hospital, it was the same surgeons, but not the same anaesthetists. So therefore your ERAS compliance was more difficult to apply. I was able to conduct an ad hoc induction program in that hospital. And I was also fortunate enough to work there 1 shift a week to make sure that the patients were getting the best ERAS care that they could possibly get under those circumstances. Of course, data was not collected at that time, but we were still ensuring that they had the same follow-up mechanism and that the principles were still applied. Pretty much the same as you, all non-COVID research stopped, all nurse specialists and nurse practitioners were redeployed, included. So I started working in a general surgical ward, which was interesting. All the patient groups were mixed up. We had COVID positive and non-COVID patients in different parts of the hospital. Critical care areas were often reaching capacity, so we had to turn recovery area into an intensive care step-down unit. Staff were moved. We were very stressed, it's fair to say. And so focus has definitely shifted during the pandemic, and ERAS and other quality and service improvement initiatives have temporarily been set aside. However, as you've said, Valerie, that when elective surgery has resumed, we were very quick to reapply the ERAS principles that we know helps. And certainly at the moment, we've got a backlog of cases. We know that this thing works, so therefore we will be spending extra time making sure that people know what it is that we're supposed to be doing. The priority now, of course, is to make sure that people get their surgeries as soon as possible. We need to get them involved in the ERAS programs as much as we can. And we won't yet know the sort of consequences of delaying these patients' surgeries, or the fact that they didn't attend their clinic appointments and so on. I'm already seeing some patients with acute obstructive symptoms, as opposed to they may have sought help quicker. So one positive thing, though, that I've seen during the pandemic is our ability to change things and adapt quickly if we're all on the same page and we all have the same goal. We were able to run virtual clinics. We've opened other departments and retrained staff. We've produced vaccinations. We've now got a mass vaccination program running in the UK. We had a fairly clear message to the public about what their job was. And imagine what we can do if we set this precedent to apply ERAS to all of our patients. You know, give them a job, make sure that they follow the guidelines, work together to try and achieve the same outcomes. You know, I'm just spitballing here, but what do you think? What's the priorities for you, Valerie? What do you see as the key things that we need to change?
Well, I think like you, if I do a short summary, our hospitals have set up similar organizations in a very short time. COVID and non-COVID units, reduction of the surgical program, or deployment of staff in the most critical departments. And the entire ERAS process was difficult to implement for logistical reasons, of course. But if you look at the positive side of this pandemic, as you just mentioned before, we can see that there is an asset that allows the patient to recover better after the operation and reduce the workload by making the patient more autonomous more quickly. And I think another aspect is the development of new manner of communications, such as video calls. And I think this is an avenue to be explored and is very promising for the future. And yes, I think this pandemic, we will learn a lot about how to treat our patients in the future with ERAS and the benefit of ERAS in this case.
I agree. Thank you very much, Valerie. It's been nice to speak to you. Take care.
Thank you too, Angie. Take care too. Bye-bye.
Bye-bye. Bye.
Thank you, Angie and Valerie, for that double act. It's very interesting to know that the problems faced by nurses were very similar in the two healthcare setups, and also the interventions used to mitigate the problems were fairly similar. We now move on to a slightly different part of the program, and we're going to see how COVID was managed in different parts of the world. And the first speaker in this section of the program is Kwang Yong Hao, who's from Tang Sheng Shock Hospital from from Singapore. And he's going to talk to us about the perspective from Singapore. Thank you.
Good day to everyone. It's a privilege to be speaking at this ERAS webinar. I'm Kwang Yong Hao, a colorectal surgeon from Singapore. For the next 4 to 5 minutes, I'd like to share from an Asian country's perspective of how we continue to persevere with ERAS during this pandemic. Where I work in Tan Tock Seng Hospital, we are also the designated National Center for Infectious Disease. At the peak of the COVID-19 outbreak, we catered for up to 70% of the nation's COVID-19 patients who required hospital care. In order to serve this function, adjustments had to be made to the usual clinical services. Surgery was one of the first services to be cut back. Non-essential surgery were delayed or cancelled. At the peak of the outbreak, our elective surgery services were reduced by 70%. Cancer surgery was given priority, while non-life-threatening conditions like knee replacement surgeries took a bigger hit. 2 of the surgeries on our ERAS program, colorectal surgery and knee replacement surgery, showed a 25% and 40% reduction in surgical volume in 2020, respectively. As a direct consequence of closed operating theaters, the waiting time increased by 60% for colorectal cancer surgery, while that for knee replacement surgery increased by 50%. Disruptions to ERAS workflows due to COVID-19 came in the form of redeployment of surgeons and surgical nurses to COVID-19 screening centers and wards, and the complete conversion of surgical wards to COVID-19 wards. This meant that ERAS patients were cared for in wards and by staff members who were unfamiliar with ERAS practices. Now, as an established center for ERAS for the last 5 years, we have consistently maintained our ERAS compliance in the high 60s to 70s, and our length of stay after implementation for colorectal surgery has been maintained at a median of 5 days. But these disruptions due to the pandemic resulted in an appreciable drop in compliance in 2020. Now, we compared 2019 and 2020 data, and although the median length of stay were the same, ERAS compliance showed an overall dip of about 2%. During the peak of COVID-19 outbreak, we observed a decrease in compliance in all phases of perioperative care, which coincided with the closure of and diversion of surgical manpower. But this was especially significant in the post-operative phase. More importantly, when we correlated this with the post-operative complication rates in 2020, we observed that there was an increase in the overall complication rates in the same period of surgical ward closures and surgical manpower redeployment. Complication rates fell in the second half of the year when normal surgical services were restored and ERAS workflows resumed. Just from our observations of the 2020 data, we can see that ERAS practices can be continued even during the crisis, and we can still achieve respectable outcomes in compliance. Yet we can also see that disruptions to our usual ERAS workflow may still have an impact on compliance and complications. Some of the mitigating factors that have helped cushion the impact of COVID-19 on our program includes an ERAS program that has gone through a systematic implementation process and matured over 5 years. This has helped to create a culture of increased awareness of ERAS throughout the surgical division and not just within the ERAS team. At the same time, there is collective leadership and ownership of the program, and we see colleagues of different seniorities stepping up to help cover the shortfall in manpower. For example, surgeons and senior nursing clinicians have taken over the job of ambulating the patients on post-op day 0. We also took the opportunity of reduced surgical load to conduct ERAS implementation programs and refresher courses within the hospital with safe distancing measures in place. At a regional level, we continue to partner ERAS Society to train other centers in Asia through online ERAS implementation programs. Finally, how can we do better? Firstly, we have seen that disruptions to the established workflow and a team can upset the balance of even a well-oiled system. Therefore, to soften the impact of these disruptions during such crisis, we need to cultivate an ERAS ecosystem that is less dependent on specific individuals or even specialized ERAS teams. One way is to start introducing the concept of perioperative care early in the training, such as in medical or nursing schools. Secondly, we recognize the importance of continuous data collection and audit, but we need to find a way to make data capturing and flow more intelligent and efficient. There is no easy solution to this, but it will be vital for sustainability in the long term. Lastly, I would like to suggest that as a society, we can try to dispel the notion of ERAS versus non-ERAS patients. Perhaps as a victim of its own success, ERAS may have inadvertently created a dichotomy in perioperative care into ERAS and non-ERAS care. The result is that ERAS patients may routinely receive more attention, therefore potentially diverting resources away from non-ERAS patients. Now, this is certainly not the intention of ERAS, and we need to refocus the objective of making ERAS the accepted standard of perioperative care for all surgical patients, rather than for a specialized group of patients. In conclusion, it is possible and it is important to continue ERAS practices during a pandemic. And this can be done through collective leadership and ownership, and that is crucial to the success. We need to improve the efficiency and have less reliance on manpower for data collection. Finally, we need to establish an ERAS ecosystem that is resilient to all disruptions and accept ERAS as a standard of care for all surgeries. Thank you.
So thank you, Dr. Kwang Young Hao. And it's very interesting to see how COVID-19 perspective is from Asia. I would now like to introduce Professor Nicolas Desmartins. And Professor Desmartins is Professor of Surgery and Chairman of the Department for Visceral Surgery at the University Hospital of Chuve in Lausanne, Switzerland. He is also Chairman of the ERAS implementation program, and his today's talk will about COVID-19 and the perspective from Europe. Please go ahead, Professor Desmartins.
Hello, everybody. Great to be here, even if it is only electronically. In this ERAS webinar, I will show you some figure about Switzerland and the way we could use ERAS to improving surgical outcome. On this slide, you see something which is very known as for the beginning of February, you see the worldwide number of cases and the worldwide number of deceased patients. This is here how we have in Switzerland. Since 1 year, we had 500,000 cases with almost 10,000 deaths. And what you see, the 20 last day, COVID is slowly decreasing, but the situation is far from being normal. If we see the Switzerland for a population of 8.6 million inhabitants, half million deaths, but the mortality is 1.64, which is not a very low mortality for this disease. In our own hospital, you see on this slide, the COVID cases for the first wave. It was starting at the end of February, so exactly 1 year from now. And you see that the first wave came with 150 cases at the same time in our hospital, which is about 10% of our hospital capacity. This doubled for the second wave with the peak in November with almost 300 cases in our hospital, which is a little more than 20% of the patient population of the hospital had COVID. This is on this slide how you see the death rate by the first and here by the second wave. And you see that the second wave was lasting longer and we have way more death patients, but we learned from the first wave what's concerned the operating schedule, which is our topic today. Maybe something about the people who don't think really that COVID had an excess mortality. You see in red between 2015 and 2019, the expected rate in Switzerland changing every week. And you see here the excess measured rate death in the first wave, and here you see exactly the same for the second wave. So we definitively had an excess mortality in Switzerland, like probably in the rest of the world. If we compare the first and the second waves, we see the two things. The first wave was strong and we were hit and we were afraid because we saw what's happened in China and in northern Italy with the waiting people in front of the hospital and totally overloaded the hospitals, facilities and intensive care unit. So we blocked our operating program, and I will be back in a few seconds on what's happening exactly. When you see the second wave, it was way higher than the first wave, and it's decreased much slower. You see the date today where we are recording this this video is the 23rd of February, and we just passed 100 patients in our hospital, but we still have 100 patients in the hospital. And actually, if we make a comparison, the evolution per 10 days is only -1%, which has some consequences, because during the first wave, when we had a decrease, the decrease was about 4% per 10 days. So as you saw just before, the first wave decrease in COVID cases way slower. The consequences is that we had to increase dramatically the number of intensive care beds unit, and we decreased massively, and this is the problem, our operating room from 16 in the main operating facility to 6. So the surgical activity decreased from 100%, actually 105% is the real figure, to 30% with variation depending on the specialties. If we look during the first wave only for the digestive surgery, we had a decrease in 40% in operation. We decreased the operating capacity, but we increased the length of exploitation of the operating room. Why did we have to decrease the operating room? Because anesthesiologists and the operating personnel staff had to go to the intensive care unit to take care of the COVID patient. And actually, if we look at this paper who assess the post-COVID surgical backlog, we are worldwide at over 40 million patients who need a new operation because it was postponed. And that brings to the main message of what an ERAS pathway can bring as a contribution to improving the surgical outcome and improving the surgical capacity is the use of a strategy. The strategy, by definition, is the planning of an action. So you have the surgical strategy, part of the global management of the patient. You have the strategy of every patient management, and you have the perioperative strategy. When we speak from surgical strategy, this is surgery and technique, the way we will do the operation, when, how, and what kind of surgery we will use. When we discuss the strategy of patient management, this is multidisciplinary with medical oncology, radiology, and so forth. And this is also a first step to ERAS. And if we look at the perioperative strategy, we have ERAS as a definition of the perioperative strategy, which is the global management of the patient with surgeon, anesthesiologist, and the nurses personnel. So if we look at this COVID-19 and surgery and ERAS, we know that ERAS decreases the complication by 20 to 50%. And this is very important because actually since we apply ERAS for liver and pancreas surgery, those patients do not go to the intensive care unit, which is very important because in this pandemic of COVID-19, we have a lot of need for the intensive care unit facility. And of course, ERAS decreases the length of stay and the cost. ERAS, as you know, is a global surgical strategy, and this is a dramatic improvement of the entire perioperative management. And I will show you a summary of the current figure we have in our hospital. You see here that ERAS is effective. This is the number of patients we did treat, colorectal, pancreas, liver, and upper GI. You see the number of patients, you see the decrease in complications, and you see the decrease in length of stay. And what is very important as well, this is the complication. And what is very important as well, it is also cost effective. And if we look, something very interesting for the nurses, especially in this time where we are short of nurses, sorry, those are first the cost, doesn't matter. The cost is decreased, Swiss franc, US dollar or euro is more or less the same. And you see that we have per patient applying an ERAS protocol, a massive decrease in cost per patient. What is also interesting is the nursing workload, which is very important, is this period of need for staff in the hospital due to the COVID pandemic. We decreased the working load in colorectal patient. We did not measure it in other specialty by 45 minutes per day, which is absolutely amazing. But this is just for my department. The savings are over $8 million, Swiss franc or euro, more or less the same. But in addition, we have treated based on ERAS pathway, lungs, urology, gynecology, and so we had saving about 16,000 beds and $13 million over the years. So this saving in beds is very effective and very important during a COVID pandemic. And in this period of COVID, it's not time to relax now. We need to have hand disinfection, mask, social distanciation, vaccination whenever available. We should apply widely ERAS in the surgical activity, and we should be very cautious. And actually, I'm afraid sometimes the measure we have to work against the COVID as not as efficient as they could be, which is a pity, but nevertheless, we will come over this COVID pandemic. And this is my place. This is yesterday. I'm done with this presentation. Thank you very much for your attention indeed.
Thank you, Nicholas, for sharing the Swiss perspective with us. Before we move on to the next speaker, I would like to remind the audience that you can ask questions on the Q&A line, and we'll try and answer as many questions as possible when we have the panel discussion. We now move over to the African perspective, and I'd like to invite Dr. Robbie Oded, who's a consultant surgeon in Cape Town, and is also the African lead for the ERAS program, and is the lead for global surgery at the University of Cape Town. Over to you, Robbie.
Good afternoon, and thank you for the kind invitation. I'll briefly outline the South African perspective pre-COVID, the impact of COVID, and present possible areas that we can make a meaningful impact. South Africa has a population of 59 million, an unemployment rate of 30%, and an economy that's struggling. And just prior to lockdown, the International Rating Agency downgraded our investment status to junk. We've long struggled with the quadruple burden of disease of HIV, trauma, cancer, and communicable diseases. What we've seen with the introduction of antiretroviral treatment, that HIV numbers have decreased, but trauma and cancer numbers have increased. We've all seen these stats of poor access to healthcare in Africa. But what we often forget, that those patients that are fortunate enough to have access to care often have poorer outcomes than patients in high-income countries. We had our first case of COVID in March 2020. We've just come through our second peak, and we've had about 1.5 million cases with just under 50,000 deaths. If you take a more global view at a glance, it will appear as though Africa has come through this relatively unscathed. But if you look at the data a little bit more closely, there's a few questions. The first is the number of excess deaths during these spikes, which remained unexplained, but likely to be due to COVID. The second is that there are many countries still in Africa that deny that COVID even exists. And the third issue is the fact that we don't have a standardized reporting system, and only 8 out of 54 countries have a compulsory system to register deaths. The economy is expected to shrink by more than 50% in this period. And the question is going to be is, how are we going to get funding for the NHI and the INSOPs? In addition, it's going to take approximately 4 years for us to get back to our previously poor baseline. We're likely to see increasing numbers of patients needing care in view of the hard lockdown and cancellation of elective work. On the plus side, our trauma numbers have decreased significantly during the lockdown, and our busiest trauma unit on the 1st of January had no patients, a first in its history. Some of the other positives is that the profession is much more receptive to change, they're open to new ideas, and they are more receptive to value-based care. Team approach and working as a collective is proving important, and the commitment to the National Health Insurance and NSOPs remain. And a huge positive is that we've commenced our vaccine rollout a week ago. So in summary, pre-COVID, South Africa, as in most of Africa, we were struggling with huge surgical and anesthetic backlogs, poor outcomes even for patients who did have access, lack of quality data, and fragile economies. The COVID pandemic is going to place a huge burden on the economy in Africa. But on the refreshing side is the fact that all the role players are receptive to change, and there's renewed energy in working together as a collective. And I do believe that ERAS provides the solution to the value-based care that we so desperately need. So what are the low-hanging fruit that we can target? ERAS implementation in academic institutions and private sector should be fairly straightforward to do. The LMIC guidelines for secondary hospitals is going to prove invaluable, and we've started working that. The implementation program, we're looking at ways on how to make this virtual, which allow us to reach a wider audience. We need to improve our African and LMIC network, and we need to commit to expanding the INSOPs within ERAS. And when we drill down on this, what we really need is seed funding to get started. Thank you very much.
Thank you, Dr. Audit, for your excellent presentation. And it's always very impressive to hear the COVID-19 results on South Africa. So the next speaker is Professor Greg Nelson, and I'd like to introduce him. And Professor Nelson is Chief of Gynecology at the Tom Baker Cancer Institute in Calgary, Alberta, in Canada. He is also the Secretary of the ERAS Society. So please go ahead, Professor Nelson.
Thank you very much for the opportunity to present to you today the perspective from North America. So certainly we can see from some of the headlines the impacts of COVID-19 on surgery in North America. Lots of patients are feeling anxious about having to wait for their surgery, especially if it was delayed. We're also seeing questions about the appropriateness of having elective surgery during the pandemic, and also certain types of surgery, such as cancer surgery, whether or not those can go on. So how bad is the problem? Well, certainly in Canada, where I'm from, this study in the Canadian Medical Association Journal had the goal to estimate the size of non-emergent surgical backlog during COVID-19 in Ontario. Ontario is the largest province in Canada. Basically, during March and June of 2020, they estimated the backlog to be about 150,000 surgeries, and they estimated that it would take approximately 84 weeks to clear that backlog. And they indicated that they would require a weekly throughput of over 700 patients, requiring 720 operating room hours, 265 ward beds, and 9 ICU beds. So not an insignificant challenge, to say the least. How about in the United States? This report that was put out by the McKinsey & Company consulting firm, they surveyed 25 US hospital systems in July 2020, and this collectively represents approximately a quarter of all hospital beds in the United States. The providers surveyed said that there was approximately 35% decrease in surgical volumes during that period compared to the year prior. And obviously there's a different healthcare system in the United States compared to Canada. But basically, from a financial standpoint, they indicated that this reduction in elective surgical volume would have an impact of approximately $200 billion in financial losses for hospitals and health systems during that time period. They also examined barriers to increase elective surgery volume to address the problem. And we can see here some of the top reasons why respondents indicated that it could be a challenge. So the number one challenge was workforce shortages, inpatient bed availability, OR room capacity, COVID-19 testing, PPE shortages. When we look at how enhanced recovery after surgery could potentially address some of these, it becomes obvious that, first of all, inpatient bed availability could be addressed by ERAS, just from the standpoint of increasing capacity and throughput. They also asked the respondents about particular actions that they might be taking in the next 3 months to increase surgical throughput. Again, some of the top choices were to extend the hours of operation each day, look at contacting patients to try to limit cancellations. One obviously of interest to our group is to focus on optimizing the length of stay for inpatients. Again, enhanced recovery after surgery would be something that could address this. And then finally, the American College of Surgeons has provided a number of excellent resources to try to address COVID-19 and surgery. This is one example, a roadmap for maintaining essential surgery during the COVID-19 pandemic. And this specific example here that they highlight in their document around phase 4 or post-operative phase to emphasize standardized protocols which optimize length of stay efficiency and decrease complications. And they specifically name ERAS as a potential solution for this. So thank you very much, and I look forward to the discussion.
Thank you, Greg. We now move to the last talk of the session, and I'd like to introduce Professor Adrian Alvarez, who's a rather rare beast because he trained both as a surgeon and as an anesthetist. He's a staff anesthetist in Buenos Aires, and he's also the leader for ERAS in LATAM countries. Adrian.
Good morning. I will talk today about our situation in Latin America. I will comment some experiences lived during these challenging times, and I will finish with some conclusions. Latin America has a population of 650 million people. 250 million are below the line of poverty. 100 million lives with less than $1.25 per day, which means they are in extreme poverty. 500 million of the population is considered economically vulnerable. That means that those families totally depend on the salary they get for their job, and if they lose it, they will enter almost immediately into poverty. These catastrophic numbers are before COVID-19, so we can imagine how desperate the situation will be after the pandemic. Chronic economic crisis plus inefficiency, high levels of corruption, lack of leadership, and lack of social commitment leads to the inevitable collapse of healthcare systems. Here we can see pictures of real hospitals in Latin America before COVID. The consequences of poverty, inequity, and lack of satisfaction of the most basic needs like healthcare inevitably leads to social outbreaks and violence like we can see in this map. But the pandemic was also an opportunity to promote changes and to adapt to a new challenge. One example is what happened with the implementation programs in Latin America. On March 2019, I was ready to fly to Sao Paulo to train 8 hospitals in Seminar 2. The following week, I was planning to fly to Uruguay to start an implementation program in a new unit in Montevideo. The seminar in Brazil was canceled, and the following day, the borders between Argentina and Brazil were closed. Obviously, the training in Uruguay was also canceled. Once the initial shock after the pandemic calmed down, we started to think how this situation could be managed. We realized that it would not be possible to travel for a long time, and also live meetings were going to be impossible. It was necessary to find a way to do the training online. We needed to create a tool effective, feasible, and affordable for all. It was crucial to find leaders capable of facing this change management project in the middle of a pandemic never seen before. And finally, a strong commitment of everyone involved in the process was mandatory. We will finish these trainings soon in all units, but so far, as a result, we have seen a reduction in length of stay between 30 to 40%, a variation in compliance from 35% in pre-ERAS phase to 70 and even 90% in the ERAS phase. We have estimated savings, no flights, no hotels, no food, of $14,000 for Brazil and $5,000 for Uruguay compared to live trainings like we used to do before. This is just an example about how solutions can be found even in very adverse situations when you have awareness, efficiency, leadership, and commitment. So as a conclusion, what do we need? We need a diagnosis to know where the problems are and which is the magnitude. We need an effective method to solve those problems. We need a plan about how to do this in a continental scale. And we need a system to train and to supervise the new units. ERAS is a system with all those features. ERAS could be the solution. We need a system like that to reach every patient in our region. We need compassion and equanimity. In other words, empathy and non-discrimination. Our goal is timely access to safe and affordable surgery for all. Thank you very much.
So thank you, Professor Alvarez, for your interesting talk. We are running a little bit late, but we have some nice questions. So we propose to go ahead for 10 or 15 minutes. And I would like to introduce the Q&A panel. And all the panelists are members of the executive committee of the ERAS Society. And first, I will introduce Tom Wainwright from the UK. He's a physiotherapist. Ulf Gustafsson, surgeon from Sweden. And Chris Jones, he is anesthetist from the UK. And of course, Bill Fawcett, also anesthesiologist from the UK. So I would like to give the word to Dilip Lobo because he has a question.
Thank you, Hans. I'd like to ask a question to the panelists, and you've all spoken about the procedures taken to mitigate harm to the patients. But what in your local healthcare setups has been done to mitigate the anxiety felt by healthcare professionals? Anyone from the panel is prepared to answer?
I can start off. I think that in Sweden, I think the issue here, at least in the early phase, was the availability of protective gear. That was something that was a big debate here early on, and I think that was really one of the headlines. I'd like to hear from around the globe about this issue. Perhaps we can move to Asia.
Wang Yang?
Hi, yep. Hi there, hi Go. Thank you very much. Yep, so I think this was an issue, the anxiety that is felt by the healthcare professionals was very much high at the start when we all knew very little about the virus. But along the way, with more information and the fact that we were equipped with the necessary personal protective equipment, protocols to make sure that we keep between the clean and the dirty, in a sense, you know, and so as to speak, that the patient groups and the working sites, that gave more reassurance to the healthcare professionals to carry out their duties with greater ease of mind.
And maybe I can explain the Netherlands situation because very importantly, already the things which were addressed is like the testing capacity and the strategy of the testing of patients, but also of the healthcare providers. This was really an issue, and this was sorted out in the several weeks of the first wave. But that was really a kind of a trouble to address this accordingly and nationwide.
Adrian and Greg, do you want to add anything?
Yeah, I was just going to say we have kind of an interesting perspective here. You know, we're getting a handle on COVID, but interestingly, many of the ERAS teams are wanting to re-engage and get working, and some of the local executive you know, are saying that, you know, we really need to focus on COVID. Surgical teams, we probably can't support them to come together to work on the ERAS activities. And so I've really had to push back to say, you know, we absolutely need to be working together to get our ERAS teams back and running during this time. So just an interesting barrier that I hadn't really anticipated.
Thank you. There's a question from the audience. It's Peter Bulwer. It says the case for ERAS is well established and is widely implemented in some surgical disciplines, but not so often in others, for example, trauma and orthopedics. How can we change that? Ole? You're muted.
Okay, here we go. Yeah, we have guidelines that just came out for hip and knee replacement. Spine just came out, so it's moving into orthopedic surgery as well. And we are just about ready to publish one of the emergency laparotomy paper. It's coming out. So it is certainly moving into this direction. And there's a group working on also more trauma surgery. So it's coming.
I think it's a good question because orthopedics is actually a significant part, a significant percentage of major surgery. And it has been slow. I mean, it's been 10 years or more behind colorectal, but I think that there's been fine work done, particularly by Tom Wainwright, to finally have a workable consensus to take orthopedic surgery forward.
Yeah, and I could add to that I think a lot of the inspiration that we've had, and I know Thomas had, has come from Denmark, where they have organized this in a very specific way, and we must pay credit also to Henrik Kellett for the work he's done in this respect, I think.
Okay.
If I can just, sorry, I can just add, I think maybe from a practical point of view, I was just saying that as we all always emphasize that doing ERAS is not just about having a protocol. And really, if you have already started with a established program like for colorectal or one of the GI protocols, then having that infrastructure and the workflows that's been built for these existing protocols makes it easier than to spread it to other protocols. So I think that's a very important point.
I've got a question for the panelists and also for the speakers. I mean, we saw in the first wave that within about 2 to 3 weeks, our whole healthcare system is changed completely different from previous COVID-19. So the question actually is what can we learn from this change management we had in 2-3 weeks? Can we have some learning points from that as well for our implementation of ERAS globally?
Why don't we ask over in Latin America or Africa?
I think it's a very interesting question. And this is, from my perspective, at least, a huge opportunity to change how we see the reality, how we see the present moment, because this is affecting all of us. It doesn't matter if you live in Europe, if you live in Africa, or if you live anywhere. All of us know that this can affect us, and the only way to make it more or better for all is to be able to reach all. And I think that COVID-19 gave us the opportunity to realize that we have to be aware and that we have to be ready to help anyone, everywhere. So from that point of view, this has been very positive. And it has promoted a readiness to change. And I think that would be excellent to move forward this kind of approach to surgery like ERAS is proposing since a long time ago. In fact, I believe that here in Latin America, the problem is not to prove that ERAS is the way. The problem is how can we make it possible for everyone? That's how I see it here in Latin America.
Thank you. There's a question, I think, for Tim from Lisa Elgard. It says, just curious about the Fitbit. Will it enhance patient involvement in the pre and post-operative setting? Tim, you're muted.
So I think to a great extent, Fitbit and similar technologies has been mainly used in research scenarios as a way of monitoring patient activity prior to surgery and as a way to encourage patients to improve their aerobic fitness for surgery. It's not just Fitbit, but other similar technologies I'm sure are going to be used in the future in that regard. And I think the fact that during this pandemic, it's been much more difficult to see the patients prior to surgery and have that one-to-one contact in terms of prehabilitation. We all know that prehabilitation for patients preoperatively is a very, outside of a trial, is actually a very difficult thing to engage with and to get results from. And so I think the use of this sort of technology may help. Is that a good answer? I don't know.
As good as any. I've got a question for the speakers, and anyone can take it. Do you think we're going to see more litigation post-COVID for patients who've come to harm because of delayed surgery? And how are we going to manage this litigation?
So I think the UK perspective, Dilip, which you'll know as well as me, is that I don't think there's going to be a sort of litigation holiday. I suspect that there will be cases, and we have to ensure that we're well prepared in the way that we document our management and deal with complaints, that we've been seen to act in the best possible way. But I don't think that we can hide behind the excuse of COVID.
Any other perspective on this?
I think there are many reasons why patients might be presenting late or in a delayed fashion, and it starts with actually the patient themselves.
Yeah.
Secondarily, their interaction with their primary care practitioners, and then delays in investigation, and then delays in access to surgery. There's all sorts of layers of potential delay, but actually a lot of the delay we're seeing is with patients actually not coming forward. So you can't necessarily blame a health system for that. And so we'll see. I mean, I hope there won't be too much litigation. I think there is a general understanding of what's happened in the UK, and I don't see a lot of people litigating because they've had a delayed diagnosis, but it remains to be seen.
Dilip, can I ask a question? Because this really leads into what can we expect as far as, or what are we seeing as far as patient delay and then doctor's delay? Because I think that might be a little bit different around the world as well. Maybe Greg can start, and I'd like to hear the situation in place South Africa also.
Yeah, so you know, during the peak time, you know, we were really focusing on only seeing the urgent cancer patients and then having to prioritize those. We are still seeing some decrease in surgical access for some of the non-urgent surgeries. So fortunately, however, for my cancer patients, you know, we're now seeing patients quite quickly, and I'm able to operate because I've actually, you know, being able to use, you know, operation or OR time that other surgeons are not able to use. So I think cancer is moving forward, but I think there's still a problem for accessing sort of non-urgent care, at least locally.
On the same point, I think one of the obstacles was in terms, at least for a GI or colorectal surgeon, is performing endoscopy. Because I think there were a lot of concerns with regards to aerosolizing procedures, whether a colonoscopy was an aerosolizing procedure. So I think, at least in Singapore, there was a significant delay in, you know, or rather a postponement of scheduled scopes. So it'll be interesting to see whether, you know, in the next year, in this coming year, will there be more delayed presentations of cancers, or whether these cancers will come in with acute presentations like obstructions. But I think that's needs time to be borne out. So I think hopefully those delays in diagnosis, especially in terms of procedural diagnosis, will not lead to an increase in litigation or delayed presentations.
Yeah, from the...
Sorry, Ravi, are you answering now? Yeah.
Yeah, sorry, did it? Yeah, so just from the South African perspective, I think we've initially cancelled all elective endoscopy and surgery. So it's very much the same with huge backlogs. And the profession itself, we've lost lots of colleagues, nurses, doctors, support staff along the way from COVID. And it's usually people in the mid-career, so people with lots of experience who could be putting a lot more back into the system in the years ahead are lost. So I think we're going to see yet another void in that. The question about the medical legal aspect, what we get the sense of, there's very much more an open, receptive feeling towards the profession rather than anger and frustration as we've had in the past. And I think the COVID situation has created awareness, the big contribution the profession has made as a whole. The question I'd like to ask the panel, though, is that what do we see as the next key step that the ERAS Society has got to do to get ERAS as the standard of care perioperatively globally, especially in the low middle income countries?
Adrian, I know you have ideas.
Yeah, I have some ideas. I think that what we need to do is to see which is the reality in different places, because you can be on a cruise, but the situation is going to be different if you are in summer in the Mediterranean Sea or if you are in the Titanic. So the priorities are going to be different. I see Europe and Canada and North America like being in a cruise in the Caribbean Sea. And I think that maybe Ravi and myself are in the Titanic. So we have to look for different priorities in our different situations. I believe, truly believe, that the method, we already know it. It has to be the ERAS way. The thing that is the real challenge is how we can make this accessible and affordable for everyone. I am not a religious person, but I really like very much the Buddhist philosophy of living. And I cannot live calmly if I see that there is a lot of people in my continent, the majority of the people, that is dying because of totally preventable things, that are suffering, totally preventable things, not only surgery, but also food, education, and everything. So I believe that the first step is to bring awareness of the urgency that we have here in my continent, but also everywhere in different parts. That is the first step. We need to have data, because Ravi also mentioned that in his presentation. You have data, we don't have data. So we have to bring also the awareness about the need of data, of a network, because it is not very rational to apply in my continent some nutritional recommendations based on works that has been done in Copenhagen by Henrik, while we have people here that don't need anything. So it is not logical to apply the same thing. We have to create a network of research in our own regions, and we need to be together and find a way how this can be done in a public hospital that doesn't have money even to buy antibiotics. So that is my perspective. It is very before what we can do in ERAS to get it better.
Yeah, I think this is why we're so happy to have people from all these different places around the world helping us to develop these things. And I know, Ravi, you are about to embark on guidelines that will be suited for the low and middle income countries. And we are also seeing that there's support from that, for that. So could you give words about that, please?
Sure. Yeah, so I think from our experience, what we see that the current format of the ERAS guidelines are being specialist driven works very well in Africa, in the tertiary hospitals and the private sector. But in the public sector, a lot of the major conditions are actually done in secondary hospitals. And if you look at the DCP3 operations that's required to be addressed as a priority, they're all done in secondary hospitals, where you need more generic global guidelines. And I think that's going to make a big difference if we can combine that with a database, because that suddenly is going to give us some powerful data. I think, though, what my sense is that for South America and Africa to get started is that we need some startup capital. That if we can go to the big funders and put together the plan of how we see it happening and motivate to start a funding, because you can't ask a country or a government to invest in a program when there is no money. But if we can give them the funding to get them started, they can then in the future down the line benefit from the cost savings and allow the program to expand. And I think if we looked at the data from that the 10 richest men could provide the funding to vaccinate every human being on this planet, why can't we go and ask them for funding to get perioperative care optimized? So I think we got to maybe start looking a little bit broader in the way we approach it.
Thank you. Let me just say a few words as I'm going to hand over to Dilip and Hans to finish it off. But I'd like to thank everyone for being on board and helping us to put together this program today. It's a pleasure to working with all of you, and we'd like all of us to see ERAS moving forward all over the globe as best as we can, especially now. So with that, I'll hand over to our moderators. And again,
thank you, Oli. Yes, I think we've had a very successful webinar, and this is the first in a series of webinars, and we'll probably be having them every 2 or 3 months. So before bringing this to a close, I would like to thank all the speakers and panelists for the excellent interaction that we've had and for the thought-provoking talks. I would like to thank 3M for the unrestricted grant that they gave us to make this possible, and also Goose for the excellent management of the talks and the webinar. The next webinar will be on the 24th of April, that's a Saturday, and it's on perioperative opioids and ERAS preventing harm. We shall announce the program and the times very shortly. And finally, I would like to thank Bill Fawcett in a very special way, because he's the brains behind these webinars. And he has got a really interesting program for the rest of the year. Thank you very much, one and all.